Good morning, my name is Cheryl Bartlett. I'm the Director of the Bureau of Community Health and Prevention at the Massachusetts Department of Public Health. And we're here today for the kickoff of our chronic disease partnership. So thank you all for getting up early and weathering the storm out there and going through security out front and getting here on time. That's terrific. Here for about 2.5 hours, and then you'll be moving around for lunch. We have an exciting day before us. As you know, we have Dr. Giles with us from the CDC, and he is the Director of the Division of Adult Community Health. And we're excited to hear what he has to say about what's happening on a national level around coordinated chronic disease and other priorities at the CDC. And then during lunch, we have Commissioner Auerbach, who will be talking to us about healthcare reform and payment reform in Massachusetts and how that aligns with some of what we're doing around coordinated chronic disease. So we have a really exciting day, and then you'll be breaking up into your communities of practice. If you haven't selected one, we'll help you select one. We'll help you find the right one if you selected one and you're not sure about it, because this is where a lot of the work is going to be done with our partners. So thank you again for being here. So today we are, let's see if I missed anything, bringing everyone up to speed about where we are, and I want to thank those of you who participated in the planning. How many folks have been here for all of our planning meetings? Just raise your hands. An enthusiastic group who spent several long days with us really trying to figure out how we might create this statewide partnership and coordinated plan, and your work has been really valuable in shaping what we're doing. And then to increase the understanding of CDC's goals for us around health promotion and chronic disease prevention that really led us to where we are today. And then unveiling our communities of practice, and I guess we went over all this. So how we got here and where we are going. So in 2006, the Center for Disease Control and state chronic disease directors and program directors of individual categorical diseases began having conversations about, did it make sense to continue working in this categorical and siloed way, and was there a better way of working collectively and having a bigger impact on health promotion? And as we know, we have been funded historically as individual diseases. We have the heart disease and stroke program, the comprehensive cancer, the breast and cervical cancer, the asthma program, the diabetes program, the arthritis program, the healthy aging program. And really when we look at chronic disease, it's clear that there are a couple of big drivers of chronic disease, and those are lifestyle and risk factors. If we look at tobacco and obesity and the role that they play in chronic disease, we see that they really are the biggest lifestyle risk factors that we really want to do something about. And when we looked at ourselves in Massachusetts, we realized that each one of these disease programs had, I want to say, roughly around $1 million to do their job. But when we looked at what we had collectively, we had over $12 million. And what impact can we have on our state if we put $12 million of effort collectively together versus $1 million at a time trying to solve individual chronic diseases? But it took a lot of conversations because that's the way we were used to working, that's the way we were used to being funded, and it was also at a time when the economy was getting bad, and so we had to have conversations about this wasn't a way to downsize people or eliminate jobs. It wasn't our intention. Unfortunately, some of that happened coinciding with our integration efforts, which just made it more challenging, because when we ask people to think about doing things different, there's a level of trust or mistrust that makes people anxious about what is their work going to look like. Are they going to have the same identity in their work? Are they going to be doing that work at all? And so we had to have conversations of really what is integration? And is everything something to integrate? And so we kind of looked at this continuum of integration, and we've worked with an organizational development consultant to help us sort of think about, well, everything doesn't have to be integrated. Some things are just an individual project or initiative that from start to finish, you just go out and do. But then a lot of our work really was thinking about what are we each doing in these individual categorical programs. And so those were conversations that we began to have once we became a chronic disease integration state with the CDC in 2008. The CDC, after having national conversations, put out an RFP that had no funding with it, but was going to select 4 states to be pilot states, and Massachusetts was selected. And the benefit of it, while there wasn't any money attached to it, was that we could use our CDC grants in a more flexible way. And that really does make a big difference for those of you that manage grants, and particularly federal grants, that we could start to be a little bit more flexible, and every dollar we spent in diabetes didn't have to be strictly for diabetes. We could really look at what were the tasks before us, and how could we get them done with a collection of all these different budgets that we had. And that had its challenges as well. But so we were selected one of 4 states: Wisconsin, Colorado, North Carolina, and Massachusetts. In Massachusetts, one of the reasons that we were selected is we were the only state in the nation with healthcare reform. And so as we were moving into this, thinking about integration of chronic diseases, we also were thinking about what is the relevance of public health in healthcare reform, because a lot of what we did, or do, is oftentimes be the payer of last resort for people that were uninsured. So our programs were really making up for the lack of insurance coverage that we have across our state as well as the nation. So if we're not doing that, what is it that we're going to do? So we really had to go back to what is really the core of public health, and how do we build that into this new healthcare system that's happening. And so Massachusetts worked for a couple of years, 2009, 2010, on looking at what we were doing internally. And Leah Susan Oyama and I, who will be speaking to you today about sort of where we're going after I get you to where we are today, and I talked about, how could we look at our division of what was then called health, chronic disease and health promotion, or something like that. We've evolved over time, and we're now the Division of Prevention and Wellness, where all the chronic disease programs are. And we realized that our organizational structure really wasn't very conducive for us to think in this more united way, because we had a diabetes specific task or a heart specific task, and they didn't lend themselves to working together. And so we brought the chronic disease program directors together and facilitated some meetings, both ourselves and then bringing in professional facilitators to help us have this conversation that wasn't always easy about, let's see what you have for money, and let's see what you have, and let's think about what the goals are of all of our programs, and really laid out each and every intervention and strategy of the individual chronic disease programs till we really could clearly see where we already were aligned and wanting to do the same thing in communities or with professional organizations or community-based organizations. And at the same time that we were doing this, we often heard from our partners that, well, you're coming into our community to do this. Do you know that someone else at DPH is doing that? And we oftentimes didn't even know, as the State Department of Health, who was in the communities and what work were they doing. And so it was clear that integrating and streamlining what we would do certainly would help our partners as well. And so once we kind of determined what we were looking at, we realized that our work was really aligned in doing policy and systems change work at a community level, and then also doing policy and systems change work in a health system where we could really help shape payment reform, healthcare reform in a way that integrated prevention and health promotion into the work that's happening across our state. And so that sort of brought us to 2011, when the CDC, over a couple of years' time of our integration project, brought the 4 states together to sort of glean the lessons learned from all of us so that they could help to shape this for the country. And some of the lessons I think we learned is that you can't be transparent enough at a time of change and transition, and involve as many people as you can in that change and in those conversations, so people feel like they have a stake in shaping what happens and that this isn't happening to them. And even though we thought we were communicating effectively, we heard all the time, nobody's communicating to us, we don't know what's going on. And some of that was fear and anxiety based, and some of it was reality based, because every day we were making new, coming up with new ideas and new thinking around how we could do this work. So never enough communication when you're changing what you're doing. Engage people as often as you can, and we engaged the entire staff. We would have meetings and come up with thoughts and share that with staff and let them react to that. We also began to explore what those external relationships would be, because internally we had our categorical way of doing work, but many of our diseases have advocacy organization or community-based organizations that are very entrenched in a categorical way of doing their work. And so we had to say, how can we continue to maintain advocacy that's specific to individual diseases at the same time that we come together and have a bigger impact on the health in our communities. And so those conversations really are where we are today, and it's thanks to your work that we're able to come together and think about having a statewide chronic disease partnership. So again, communication and transparency and engagement really clear in how we got to where we are today. And I also just want to acknowledge the staff at DPH, because I know it was a really challenging couple years. We did have enormous budget cuts. The department lost almost $80 million over the last 3 years while we were doing this transition. And unfortunately, the Bureau of Community Health and Prevention had about a 40% budget reduction during that time period. It seemed that everybody thought that because we had healthcare reform, anything that had the word disease or health or anything to do with either of those didn't need to be funded anymore, because we had healthcare reform in Massachusetts. And so we had a lot of work to do to really convince people that we were really a backbone of healthcare reform, because we need to keep people well to reduce the cost of care that we're spending and be able to spend money on prevention in other ways that we know that people will be healthier. And so then the CDC took a lot of the lessons that we shared with them and put out an RFP, or an FOA as they call it, and we applied for it. And all 50 states were funded to have coordinated chronic disease programs. They were funded different amounts. There was sort of a baseline that states would get funded, and then states that were more ready to hit the ground running were able to get more money. So we got a grant in order to really move forward and not have to use just our individual categorical grants that we could bring together and try to create integration, but now we actually had some resources to put to this. And so we received this grant, and as a result of it, these were the tasks that we had before us that we were to create this coordinated chronic disease plan. And so in your packet, I think, or you got as you came in, the outline of our coordinated chronic disease plan. And this is really just the framework for how we intend to work together with all of you. And during our planning phase, we worked in January, February, and March, having these planning meetings, then met internally to kind of process what we learned at those meetings to see how we could continue to proceed and outline a planning process. And so we have this community of practice approach. And that was something we learned during our integration days. North Carolina really used this approach, and we really thought that that was good because it sort of superimposed this over the work that we were all doing individually, so we could still maintain some of that subject matter expertise while we then looked at what were the things we were trying to do and change in our community. And so our planning group came together and we created what the definition of chronic disease was, and that in and of itself took some time because everybody wanted to make sure every single thing we could possibly think of. And really, when we got down to the end of the day, you could really put anything to do with health into a coordinated approach to chronic disease. But we needed to back off because one of the lessons we learned in our integration effort through the State Department of Health was that we started out thinking the whole department should come to our integration meetings and everybody was going to integrate and sort of kumbaya and we're going to save the world. And all these people were sort of sitting there like, what are we doing at this meeting? And any of the things we had to share really weren't all that relevant to what they were doing. And when you're busy and you're sitting at a 2-hour meeting, you're like, what, really, I could be really getting my work done. And so we realized we were having a big enough challenge trying to bring the chronic disease programs together that were sort of required to be part of integration, and that it was sort of a lofty goal to think that we could influence people outside of our sort of sphere of influence. So we sort of came back and retracted and said, let's start out with those of us that have to be in this, and if we can figure out how to do chronic disease integration with all of the chronic diseases out of the chronic disease unit at CDC, then we think we can begin to add other subjects into what we're doing. And I think that that has sort of played out because we're doing this work and we're really, it's really exciting at the department, and the other bureaus are now saying, well, how did you do that? How did you get everybody together? And, you know, why aren't we part of it? You know, HIV, we're chronic disease now too. And so, and substance abuse, I mean, people that use alcohol, that's a chronic condition. We need to be part of it. And so from this, I really think that we'll be able to influence what our department looks like with other bureaus and other work that's happening there, and see if we can't integrate them more. And folks are here representing all of those different areas. And so before I turn this over to my colleague here, Leah Susan, I thought I would also kind of get a sense of who's here. As I told you, there's a list, and we really, with this number of people, there are over 120 people registered here today, that we couldn't really go around the room and have each of you say something, but we thought it'd be great to get a sense of who's here with us, because this, to us, is about the start of non-traditional partnerships, bringing together other sectors, and really looking at health and all policies, and having different sectors be involved in chronic disease and health promotion is a really exciting new way of thinking about health in Massachusetts. So I thought I'd start out with who's here for the first time. Lots of new people, great. Thank you for joining us. Who's here from the education sector? Who's here from the healthcare sector? Who's here from public health? Good, we're not totally dominant. Who's here from land use planning and transportation planning? Good. Who's here from housing and community development? Some of you, I see, wear a few hats. Who's here from parks and recreation? I think they're folks from the Ys. I'd say parks and recreation. Who's here from agriculture or food systems? Who's here from municipal government? No. All right. Sometimes we go to these meetings and there's no one, so having a couple people helps us change our thinking. I know, yeah, he gets the award for every sector. Who's here from elder services? Great. And is there anyone here from business? They're a real non-traditional partner, hard to get to the table, but they're not. And who's here that represents working with disparate populations or health equity? Great, awesome. Great, so as you can see, we have a lot to learn from all of you. You'll have to have loud voices to overrule us. And again, I just want to say thank you for being here and turn this over to Leah Susan Oyama. She's the Director of the Division of Prevention and Wellness, and has really been leading this charge to reorganize this division and the work that we do.
Over the last, I don't know, since I've been in the division since 2004, doing healthy communities work, we've been doing a lot of it, my staff have been doing a lot of the recruitment for the early partnerships, and people are, as Cheryl said, you know, we would go out and recruit for the Diabetes Coalition, we recruit for the Partnership for Healthy Weight, we recruit for the Partnership for Heart Healthy Stroke-Free Mass, and very often it was the same people. And people were saying on the local level, when are you going to all start working together? Message received, here we are, and we're very thrilled to be pulling that all together. As Cheryl said, I'm the director, well, I say acting, but she's just said director, so I'll say that too. Director of the Division of Prevention and Wellness, and as we've been doing this process of working on, of pulling this partnership plan together, we've also, as she said, been doing some reorganization within the division. So I was just going to get into, she talked about the fact that we talked about what we're doing in communities and schools and in work sites and then in health systems. So we're really, as we go through this process and creating an integrated plan, we're also doing that more at the department. We haven't quite gotten to our next level of how we're going to be organized, but we do see ourselves more functional units around doing work around community health and healthy communities, and then doing work around health systems, and then doing work around really what is the community clinical linkages and integration. So stay tuned for that too. That's hopefully, when we meet again in December, we'll be able to roll out, well, what do we look like at the department as a result of some of this work that we've been doing. So my role is to talk to you about what we're going to do, where we are now, and where we're going to go between now and 2016 is what you all have on your timeline. So here we are in June, and as Cheryl put it, we've done quite a bit of work to get us to this point. And you'll see that the work that we've done has been the creation of this. Again, it's just an early draft, and it's really the template moving forward. So the launch of the partnership and then unveiling initial steps is what we're going to be doing today, and then working towards a coordinated plan. And if you've heard about the work that has taken place to get us to this point, and then really for going from what's going sort of independent to more coordinated and collaboration. I think integration is all the way to the left of the continuum. I think hopefully we'll get there in some things, but as Cheryl put it, there are some things that will really still stay in the early parts of the continuum, and that makes sense. I mean, it doesn't make sense to integrate everything. It makes sense to integrate the things that it really makes sense to integrate. We said, what's the juice, to squeeze the juice. What's worth squeezing to get the juice is really what we're going to work on in integration. I didn't talk about that really well, but the person who worked with us explained it much better. But I think the point is that what we heard when we were down, at the March meeting with Dr. Giles in March, there were about 4 of us who went, is like, what can we do? Let's pick a few things that we can really do well. We have been doing a lot of things, and we've been doing things really well. But I think with changing resources, changing priorities, let's really, as we coordinate and collaborate, move towards integration, let's figure out what makes the most sense and set some priorities and do those things and do them really, really well to have the benefit for across the Commonwealth. So that's what we will be doing with your help. So what you're going to do today is we're also going to start with the communities of practice. That's also the initial meetings of the communities of practice that will start this afternoon. We've had preliminary meetings that got us to identify the primary objectives that have created these communities of practice. But the communities of practice is where we're really going to be working with you to bring the work together to get to our priority objectives. Now the communities of practice, it's not to create new work, because that's not what our goal with the communities of practice. It's to take the work that's being done across the Commonwealth by all of you and many, many more across, other partners as well, and bring that together into a more collaborative, synergistic way. There are great work that's being done that is helping to get to the objectives, but we're doing them independently. So through our initial goal with the communities of practice is to have all the people work together to bring those to work together in a new way. I take Kathy's word of we're working together in a new way. We're not doing new work, we're working together in a new way. And I think the other part of it is bringing together different types of partners. As Cheryl went, we're seeing the types of people who are in the room. Part of it for us is reaching out and starting to work more in collaboration with what people have called non-traditional partners. I call them natural partners, because I think that the important part of it is particularly if we're doing policy work and health and all policies. Transportation policy is health policy. Education policy is health policy. Housing policy is health policy. So for us, it's to work with those who are involved in those sectors to work towards creating healthier communities, to give people options to lead healthier lives. So that's really what our communities of practice is really starting to galvanize that, and so we can move forward in creating that plan. So what you'll see today is just the outline of the plan. For year one, you'll see on the timeline between August and November, we've had very aggressive timelines for this one, which I think is good. You're holding us to the fire, Dr. Giles. And we have Kathy Fell. First, I want to acknowledge Kathy Fell and Lauren Azzuti and Joshua Wosi and her group for really pulling this together for us. Cheryl and I are standing up here publicly today, but there is a lot of people behind us, behind the scenes, who've done the work. And first and foremost is the woman sitting right here, so who's helping us, because if you need to have an aggressive timeline, she's the person that you want managing the project. Chop, chop, chop. So we're doing it. So in August, between August and November, the plan is to have the first of the initial plan. This says on your timeline that you'll have in I think it's in your packets, correct? Is the full plan released. We really mean to say this is the initial draft of the plan, because what it will be is the first plan will be taking into account, like looking at those priority objectives and putting in the strategies and the activities that are being worked on currently by our partners. The next plan, a year from now, after the work of the communities of practice, is really to take the work that the communities of practice is taking that work and really strategizing and putting in, synergizing some of the work that we're doing that will create a subsequent plan to really fine-tune that plan and how we're going to get from point A to what will be in 2016, 2017. So this what you'll see here is the initial draft. In August, there will be the second initial draft, and then a year from now, after all the work in the communities of practice, we'll feel that it's more fine-tuned with the work that is being done, but also the new way that we're delivering work, not necessarily new. And then, so you'll see from 2013 to 2016, the goal is to continue to have those communities of practice be meeting to work to see how we're making progress towards our priority objectives and what we may need to do differently to get there. Do we need new additional partners? Does something all of a sudden come up that we didn't think of in the first 6 months of meeting with a group that we want to prioritize moving forward? That's the beauty of having living, breathing documents, is that they're always able to change with the change in times, change in climate, change in priorities. So that will be something that we will also be working with our partners on as well. So any questions on the process that we use to get to where we are and where we are now and where we plan to go? We're going to do a little bit more after Dr. Giles speaks about the actual plan and what's in the plan and the communities of practice. But this was just the overview of where we are. If you pull out the summary document that you have, and then as Cheryl talked about, we had a series of meetings to help us shape the partnership vision. And that was actually a great process of taking, anybody who's been through visioning before, when you're really way out here and then you sort of fine tune. And we weren't aiming for world peace. We were aiming for what was practical and looking forward. But the part of me is a vision is supposed to be really what are you aiming for? So our vision that we came up with as a group was everyone in Massachusetts enjoys a healthy community and has equal access to resources that support their choices for optimal health and well-being. So that was, what do we think? Doable? Beautiful. Okay, so we'll talk a little bit more about the communities of practice after lunch, but after Dr. Giles. But I will just go ahead and introduce Dr. Giles. I have the pleasure of introducing, we have with us today Dr. Wayne Giles, who is the Director of the Division of Population Health at the Centers for Disease Control and Prevention. You have his bio, but I will just say that I have had the pleasure of hearing Dr. Giles speak on numerous occasions, as have other people in this room. He's previously was at the Division of Adult and Community Health, where the Healthy Communities program was, and so those of us who have been doing Healthy Communities work with some of the Achieve grants have seen him on numerous occasions at Action Institutes, and I really kept coming back and saying to Cheryl, I want to bring Dr. Giles to Massachusetts. Here he is, because I think it's really wonderful to have you. As you read in his bio, he is a physician, and I think it's really great when we have people who work in healthcare who also get the community prevention side and are working cross purposes, working on those two simultaneously, because I think it's really important. Sometimes we're very siloed, and we need to really think about how does the community and the clinical setting work together in a more collaborative effort, and I think he's a great example of how that can happen. So Dr. Giles.
Great. Good morning, everybody. Good morning. It's great to see all of you here, and thank you for the invite. It's great to come to Massachusetts and to talk with you all today, and it's awesome to to hear about the amazing work that's going on, and I'm looking forward for today. I'll be here most of the day just to hear from you all in terms of what you're thinking. And I've got to say, being in Atlanta, where we think about this work, it's great to get out to the States and see it actually coming to fruition, and so that's very exciting. So one of the things that we are increasingly talking about as we're thinking about our work around chronic disease prevention and health promotion, really is, as it says on this slide, taking stock, but we also want folks to step it up a bit. And so I think that's part of what we're going to talk about, and I'll mention to you all this morning the importance of thinking about sort of how we could step things up a little bit and really have important public health impact. So I'm really going to talk about three things this morning. I'll start off talking about sort of our vision and sort of how did we get here. Very similar to sort of what Cheryl talked about Massachusetts, but sort of give you a little bit of a national perspective in terms of this. Talk about our strategy a little bit, and sort of it's really neat to see you all's mission, because I think your mission very nicely aligns with some of our strategies, and I'll talk about that a little bit. And then I'm going to end talking about the coordinated chronic disease program and opportunities that we see there. And I'm going to give you all a little bit of a call to action, because I think there's some areas where you can help the state out and you can help us as well. So it's great to see. So the first thing I want you to do is I want you to imagine a world. And I want you to imagine a world where our communities are designed so that all people have safe places for physical activity. I want you to think about a world where there are walking clubs that keep older adults and younger residents active, connected, and safe. I want you to think about a world where restaurants and grocery stores and work sites and schools and daycare centers offer affordable, healthy food options, and I would say at the appropriate portion size as well, and smoke-free environments. I want you to imagine a world where chronic disease management is supported through widespread effective changes within the healthcare system, but also in the community as well, so that it's easier for people to manage their chronic conditions. I often think about my father, who's got arthritis and high blood pressure and heart disease and diabetes, and takes some 50 medications each and every day. And as I sit there and I struggle with when I have to take one or two medications, I think, how is it that he can remember to take 50 medications a day? So what can we do in communities and within the healthcare system to make it easier for him and others like him to manage his chronic diseases? And this is from an Institute of Medicine report a couple of years ago, actually 12 years ago now, where it says it's unreasonable to expect that people will change their behavior easily when there are so many forces in the social, cultural, and physical environment that conspire against such change. If successful programs are going to be developed, attention must be given not only to the behavior of individuals, but also to the environmental context within which people live. We've got to create those environmental supports so that people can change their behavior. But the reality is very different from this. I often think about myself growing up, and when we went out to a restaurant and my father ordered, my father probably needs to get a little bit of an honorarium or something for this talk this morning. But when he would order a large soft drink, right, the size of that soft drink some 40 years ago is what today would be considered a small. So for him, his behavior has consistently been the same over the last 40 years, but the portion size has expanded. I think about the fact when I started at CDC back in 1992, when I wanted to talk with a colleague, I got out of my seat and I walked to their office. I now send them an email or an instant message. I think about when I was collaborating with a neighbor child on a science project or other school project, I got on my bike and I rode to that child's home. Now kids use Skype, text each other as they collaborate on projects. So we've engineered physical activity, healthy eating, appropriate portion size outside of around our environments. We've made it harder for people to do the healthy thing. I think about the fact when I'm jogging through parks in Atlanta, I'm jogging sometimes through people who are smoking and exposing myself to that tobacco smoke. I think about multi-unit housing and people being exposed to tobacco smoke and multi-unit housing as well. So all of those, I think, are the important challenges that we have and public health. At the same time that this is happening, we've got to be honest with ourselves. 75% of the $2 trillion we spend each and every year on health care are due to the chronic conditions that you all are wrestling with. Heart disease, diabetes, cancer, arthritis, etc. There's not a state in the nation that isn't concerned about health care costs and how they can minimize health care costs. And so we've got to think about what we can do with all this. And so with all of this, this is the reality that we are where we are today. Heart disease, cancer, chronic obstructive pulmonary disease, stroke, diabetes, Alzheimer's disease, kidney disease are all leading causes of death, both nationwide and also here in the state of Massachusetts. But I think it's important that we think about not just those diseases, but the risk factors that underlie those conditions. And I like in your plan, you have a very nice chart that shows the diseases, but then the risk factors that underlie those. And I think that's a really nice way of articulating sort of where you can have impact. So tobacco, the leading preventable cause of death, followed by poor diet and physical activity. And I also want you to think about excessive alcohol as well, which kills over 79,000 people nationwide each and every year, and also is an important risk factor for folks to consider. But it's not just about deaths that we need to be concerned about. We also need to be thinking about issues around disability and quality of life. And arthritis is the #1 cause of disability. Some 50 million Americans have arthritis. 21 million are disabled in some way because of their arthritis. Stroke has left more than 1 million Americans disabled, and heart disease is a leading cause of disability among people within the workforce. And diabetes is a leading cause of blindness and kidney failure. So again, thinking about not just deaths, but disability, we think is increasingly important. And as folks may be aware, earlier this year, the Institute of Medicine came up with a report talking about living well with chronic conditions. And I like the fact that in your vision, you talk about issues about well-being, because we see that as really important to improve the quality of life of individuals who have chronic conditions. And that needs to be a focus of some of the important work that is going on within state health departments. And in that IOM report, there are a couple of key recommendations that I think are really important as we think about this work. And #1 is that states should develop a comprehensive chronic disease plan that include community-based efforts. So I don't know if that sounds familiar to any of you all, but you all, I think, are right on track in terms of what the Institute of Medicine recommended. The second is that CDC, and I would argue, yes, CDC needs to do this, but I think states need to do this as well. That CDC and states should explore a health in all policies approach, which includes looking at health impact assessments. That's what the HIA is, health impact assessments. So this, and I'm glad to see housing and transportation and economic development in the room as well, because I think it's important that as you think about transportation policies and housing policies and economic development and all of this important work that needs to occur, that you consider what the impact of those policies might be. And among those impacts that you look at, you think about the impact that those policies potentially could have on health care. I'm sorry, on health and health care as well as part of this work. I think it's important also for us, and I'm glad to see there are a number of folks in the room that are focused on issues of equity and health disparities, but we need to remember the alarming statistics and the disparities that we have in this country, particularly as we see increasing levels of diversity in this country. The reality is we're not going to see improvements in health and well-being unless we address disparate populations. And I would argue, as we think about our roles both in public health and healthcare and business, these are really important activities that we want all citizens to achieve optimal health. And so we know that African Americans have 30% higher rates of stroke, 30% higher rates of heart attacks, 40% higher rates of stroke. If you look at young people, those 30 to 40 years of age, there the differences are even more striking. We're talking about 2 to fold increases in heart disease and stroke. Communities of color have between 1.5 to 2.3 times the rates of diabetes. And if you look at usual access to care, about 30% of Hispanics, 20% of African Americans today don't have a usual source of care. However, the reality is I think we are seeing some really striking improvements in terms of what communities have done. It's great to see and reconnect with a number of folks who've been part of Achieve and pioneering healthy communities, but we are seeing, I think, some really important improvements in communities and states across the country. In terms of obesity, particularly among our youth, clearly, if you look at the data, it looks like the rate of increase has slowed dramatically. There are also a handful of states, particularly if we look at the youngest population, those aged 2 to 5 years of age, where it looks like obesity rates are actually going down. So I think we're seeing some key progress. Now, while those rates are going down, we need to remember that in 1960, the obesity rates were down here, and now we're up here. So we still have a long way to go. But I think there are opportunities and glimmers of hope as we look at this work. And so as we think about the work that needs to occur, we think it's important that we think about sort of what are the strategies that we need to do to promote health 24/7. And so we need to think about sort of how do we promote healthy behaviors, physical activity, good nutrition, not smoking, through programs that are proven to be effective, what we'd call evidence-based interventions. We can and we should work to change the physical and social environments in communities so that the healthy choice is the easy choice in our communities. And for people who already have chronic diseases, we need to help families and individuals to better manage their chronic conditions, not only within the healthcare system, but also what can we do at the community level so that they have good supports to do the chronic disease work that needs to do. And so really, as I think about the work and that we've done at CDC over the last 20 years since I've been there, I can remember when I started back in the 1990s, we were very individually focused and very programmatically focused. And we would talk about a one-to-one interaction with a health educator and someone in the community. And we've moved from that to a much more systematic approach that talks about changing the physical and social environment, making it so that in the communities, the healthy choice is in fact the easy choice. And in order for us to do that, public health can't do that by itself. But we really need a broad coalition of folks who can help us as we move forward to do this work. And so it's great to see all of you all who are in the room today, because I think you all are the folks who can really make the important work that needs to happen to make Massachusetts a healthier place a reality. So it's great to see this broad group of folks in the room. I think it's also important because frequently as we think about the work, we think this is daunting and I'm not sure we can do this and can we really make these changes. But it's important for us to remember this is the stuff that we've always done. And so as I think about and where we as communities have come together to make this a reality. And so whether we are talking about creating safe, fresh water, requiring vaccinations for kids to go to school, food safety inspections, fortification of food, the list goes on and on, making cars safer and safer. We've always done that work. And I think the other thing that's important and why I think it's great that you all are here is because as I think about the work that needs to occur, for example, to make cars safer, public health can't do that by itself, right? But we need the car companies, we need engineers to help us figure how to do that. And so you all, that's why I think the power of we is important, because you all have to be in a room. We've got to come together to figure out how to do this. So let me spend a few minutes talking about our strategy. And as we think about the work that we do, we are increasingly talking about our work in terms of 4 major areas. And it was neat to see our mission statement this morning, because I think your mission statement very nicely aligns with these 4 areas as well. So one of the key areas that we see in a traditional area for us in public health is epidemiology and surveillance. So having the data so that we know the burden of chronic disease in the state of Massachusetts, so we know where the high burden areas of the state and community are, so that we know what's the reach of our interventions and whether we're being effective with everything. But having that epidemiology and surveillance data is vitally important. Number 2, we need to think about those environmental approaches, and I'll talk about this in more detail in just a minute. But again, how can we create those environmental supports so that the healthy choice is the easy choice? Thinking about what we can do in the healthcare system to improve care and the coordination of care. I often think about, we do a great job in healthcare in terms of providing these guidelines and recommendations, and they say care should be up here, but when you actually look at the data in terms of what people are receiving, and I'll show you examples of that in just a minute, turns out where people receiving care is down here. What can we do so that people are receiving higher quality care, particularly given all the dollars that are spent in terms of the delivery of care? What can we do to improve that quality? So working within the healthcare system is vitally important. And then the 4th domain that we talk about is this community clinical linkages. What can we do to help ensure that what happens in the community reinforces the important work that's going on in the healthcare provider's office? This is a pyramid that CDC Director Dr. Thomas Frieden published in the American Journal of Public Health, I guess a couple of years ago now, where he really talked about having public health impact. And really, what are the opportunities to have the greatest amount of public health impact? And so I want you all to focus on the rung from the second one from the bottom, changing the context. Because, so this is things like removing artificial trans fats from food, smoke-free laws, increasing the price of cigarettes, et cetera, et cetera. Those types of strategies have huge public health impact. Probably one of the things that probably has even greater impact would be socioeconomic factors. So things like increasing livable wages, increasing educational attainment, reducing unemployment will have a huge impact in terms of health and well-being. And that's something I think we all need to be striving towards, but the issue on socioeconomic factors is the amount of time it takes to see a return on that frequently takes decades for that to occur. And so that's why for CDC activities we haven't focused as heavily on the socioeconomic factors. But I would say, as you're thinking about health impact assessments, and you're thinking about issues like livable wage, how many people could be impacted by the strategies that you developed this afternoon and in the ensuing week? What is the exposure? What can you do to maximize how frequently people are exposed to that intervention or exposure? And then how can you do this in as comprehensive a manner as possible? And so I'm just going to give you a couple of examples of sort of how this potentially could work. So I guess if you look on the right side of the or I guess left side, I'm sorry, of the slide, we focus first on the 50% vending slots. And so if a community or state says we're going to make it so that in the schools, half of the slots and vending machines are reserved for healthy foods. That's an important strategy and could have impact. They may decide we're going to go bolder than that, and we're going to say we are going to get the junk food out of the cafeterias in the schools. And that's how we're going to have broader exposure, a broader impact. Or they may decide they're going to go even broader than that and look at the whole competitive foods environment in the schools. And what they're going to say is not just what gets served in the cafeteria, but we're going to look also at, for example, what gets served sort of during parties, how food is used, or is food used as a reward in schools. And then also in terms of after-school sporting events, you could think about the potential broader impact that such a policy could have. And then finally, you could do whole school reform, but you could also think about what happens as young people are walking to school. And as they go into a corner store, are they only seeing the chips and the pop, or are there opportunities for them for fresh fruits and vegetables as they go through the corner stores as well? But again, a much broader approach that potentially could have much greater public health impact. Another example would be walking to school day. So, a school or school system may decide they're going to have a day where kids are encouraged to walk to school. You could think about, instead of just doing that one day, thinking about promoting walking to school every day of the school year. You could move broader and think about having, leveraging some of the federal safe routes to school days that flow through the states so that you're creating sidewalks, bike paths that encourage kids, young people, to walk to school. You might think about creating a walking school bus. So there's a parent at the front of the line, there's a parent at the back of the line, and the kids all walk to school, creating safe opportunities for folks to walk to school. And then you could even go broader than sort of just safe routes to school and thinking about having a whole complete streets opportunity or ordinance so that you're promoting all 4 different modes of transportation. So walking with sidewalks, biking, active transportation, and then finally automobile transit. But again, having all of those modes of transportation. And again, that's maximizing the public health impact that you could have. As you think about this important work, I think it's important that you also think about issues around health equity. And in theory, as you think about policy, systems, and environmental change strategies, those strategies should affect all people across the state equally. But the reality is, because there may be varying support, there may be varying levels of enforcement, there may be selection factors, and I'll walk through an example in just a minute. The enforcement of those policies and systems changes may differ, and that may lead to issues around health equity. And so here is a community, and they've very nicely mapped the rates of obesity within that community. The darker the color, the higher the rates of obesity within the community. And what the community has decided is they said within the next 2 years we are going to establish 10 healthy corner store opportunities to increase access to fresh fruits and vegetables. And as they create those healthy corner stores, where they're going to decide to place them is they're going to talk with grocers in those areas. And they're going to look for the grocers that are most eager to have healthy corner stores and have stands for fresh fruits and vegetables as they move forward. And so they decided, they figured out where those 10 grocers are, and they've decided to map where they are. And this is what they said. And so as you're thinking about issues of equity and resources, you realize where these folks are going to go is actually the areas of the community. I would say everybody needs them, but we're missing some huge opportunities here. And so we've got to think about a different strategy. And so they go back and they say, we're not going to do 10, we're going to do 15 healthy corner store groceries. But we're going to say that 7 of these need to be in low-income neighborhoods with the greatest burden of obesity. And so we're going to have to do some additional efforts to get grocers in those communities to come on board. And then when they remap it, this is what it looks like. A much more equitable approach to moving forward, and I think a nice example of sort of issues around health equity and how we move forward. So I spent a lot of time talking about environmental approaches. Let me now move and talk a little bit about the healthcare system, and I think the importance of this work. As I said earlier, I think this work is vitally important because it's a huge cost driver. I talked earlier about the 75% of the $2 trillion, or I think it's now $2.5 trillion that's spent on healthcare due to chronic conditions. Increasingly, we are seeing employers and others looking at healthcare costs in a community and deciding where they want to locate. And so these are sort of really important strategies. We also, when I talked about this, there's huge gaps in terms of delivery of care, what we would hope to see, and where actually we are doing a good job. So for example, in hypertension treatment and control, the proportion of people who have their blood pressure adequately treated and controlled, I think it's only about 55%. So about 45% of people with high blood pressure don't have their blood pressure adequately treated and controlled. That, in my opinion, is an abomination. Colorectal cancer screening is another huge opportunity that we have. Hemoglobin A1C levels, which measure levels of glucose control among people with diabetes, another key important. We know what needs to be done in terms of treatment and control of these chronic conditions. We're not doing an effective job in it. And this is an important area for us. And then also we do have effective community-based programs that could be used to increase impact. And so this is one of the things, this is from a publication about 6 years ago that looked at sort of what are, as we think about clinical preventive services, what are the most effective, or sort of where we could actually have the greatest bang for the buck. So number one would be appropriate use of aspirin and secondary prevention for both stroke and heart attack for people who are at high risk and could benefit from aspirin. Childhood immunizations, screening for and referring people to quit lines for tobacco, colorectal cancer screening, hypertension screening, immunizations, et cetera, et cetera. You can see all the things on the list. And I think traditionally how we have thought about clinical preventive services really has been, and so much as you heard from Cheryl about chronic disease programs, has really been a very siloed approach. So we have our breast and cervical cancer screening activity, and then we have our colorectal screening program, and then we have our blood pressure screening and our cholesterol screening, and all of these are very siloed approaches. Increasingly, we've been thinking about clinical preventive services in more of a bundled strategy. Much like, with children, you have sort of the proportion of children who are up to date on their immunizations. That really, as we think about clinical preventive services among adults, we need to be thinking about them in terms of the proportion of adults who are up to date in terms of the clinical preventive services. And so here's an analysis that was published a couple of years ago. It's from data from the Behavioral Risk Factor Surveillance System, or BRFS. But it looks at the proportion of adults who are up to date in 5 different clinical preventive services. And those 5 services are immunizations, flu immunizations, mammography, colorectal cancer screening, blood pressure, and cholesterol. And again, remember, these are people over the age of 65, so they all have health insurance coverage. They all have a welcome to Medicare visit, so all of these things should be covered. And it turns out that nationwide, less than half of the people are up to date in terms of these clinical preventive services. Here in Massachusetts, you're at about 54%. So 46% of adults are not up to date in terms of these clinical preventive services. So again, highlighting that really key gap that I have. I don't think there's any reason why we shouldn't be at 100% given the resources we have in healthcare. So I think a number of things that are important as you think about the work that needs to occur. I think it's important that you think about sort of what are the strategies that we need to move forward. And I think there have been a number of studies showing that providing healthcare providers with feedback in terms of how well they are doing, how they compare with their peers, both within a healthcare system and then their peers statewide in terms of delivery of clinical preventive services and other strategies is important. Thinking about prompts and reminder systems all are effective strategies to increase both the delivery of clinical preventive services and improvements in terms of treatment and care. And so I think it's important that we think about all of those strategies as we move forward. I want to move quickly from where we are with the healthcare system to focusing on the linkages between what happens in the clinic and what happens in the community, because I think this is an important activity. And many of you have probably seen this, but this is the expanded chronic care model that's been out for a number of years. And so you all are probably very familiar as part of this with what's in the healthcare system and the work that needs to go there. And the intent there is to create a prepared, proactive practice team within the healthcare system. But we also need to remember that that system resides in a community. And so what we really want to do is create an activated community and an informed and activated patient. One of the keys that I remember, and this is, some of you may remember, our diabetes division used to be led by a gentleman named Dr. Frank Vinicor, and he used to always talk about, if you see your healthcare provider 30 minutes and see that healthcare provider 4 times a year, you will spend 0.002% of your time with that healthcare provider. And you're spending 99.98% of your time in the community. And I think that's important for us to remember, because I can remember when I was practicing and being frustrated because I would say to folks, you need to eat better, you need to be physically active, all those important things, and forgetting that 99.98% of their time, folks are being bombarded by these other messages. And so what can we do to create so that the community helps to support what's in the provider? I'm also reminded of a patient that I used to have who was overweight and had arthritis and diabetes and high blood pressure. And she said to me, I really want to lose weight. I want to start being physically active. And I said, oh, that's great. That's fantastic. Good to hear. That's fantastic. I said, let's start really small. So I just want you to start walking every day. And I just want you to walk up and down your block. And she said to me, well, it's hard for me to walk up and down. There are a number of safety issues. There's no sidewalk, et cetera, et cetera. I said, well, that's easy. I said, go to the mall and walk at the mall. And she said, well, in order for me to go to the mall to walk, I've got to take 2 buses. It's going to take me about 40 minutes to get there. So again, I think as we think about the messaging that's going on between providers and their patients, we need to also be thinking about how do we create those community supports so that she does have sidewalks, so that it is safe for her, or there are other opportunities for physical activity in her apartment complex. That's part of the work that I think we've got to think about over the next couple of years. So let me talk for a few minutes about a couple of activities that we see as being really important. One is chronic disease self-management education, and I bundle this with another program called Enhanced Fitness. And chronic disease self-management is a program out of the Stanford University. Enhanced Fitness is actually from the University of Washington. These are both low-cost, community-based classes for people with chronic conditions, but one helps physical activity, the other helps people manage their conditions. Both have shown to decrease fatigue, improve quality of life, improve functional status, and enhanced fitness has been shown to decrease hospitalizations and decreased healthcare costs. So one of the things a number of our programs are interested in, and I think this is a great example, I should say, diabetes, also in addition to chronic disease self-management, is a diabetes self-management program. These programs benefit people with heart disease, with diabetes, with arthritis, etc. And so these are opportunities for programs that really cut across multiple diseases and can have huge impact in terms of improving quality of life. And so a number of our categorical programs are focused in on what can we do to change delivery systems so that these types of programs are more systematically delivered. And so I know that there are folks here from the Y, but the Y, for example, is interested in disseminating enhanced fitness through their 2,600 Ys across the country. So Ys, I think, are a nice example. Senior centers are another important activity where they have a lot of work around chronic disease self-management and enhanced fitness, but you could think about sort of strategies of embedding these programs. A number of faith-based organizations are looking at delivery of these programs as well. But one of the key things we need to be thinking about is how do we reimburse and pay for these? And I think that's a huge opportunity for you all as you're thinking about this work, and a lot of work around this community clinical interface is how do we reimburse for this, particularly for interventions that we know decrease hospitalizations and decrease healthcare. Wanted to spend a few minutes talking about the National Diabetes Prevention Program. You all may be familiar, there was a randomized clinical trial that occurred several years ago showing that lifestyle intervention was twice as effective compared to medication in terms of preventing diabetes. But I think one of the things that randomized clinical trial was very individually focused. And so folks at Indiana University and with the Y have really looked at sort of how can we do a better job of disseminating this program and have worked with colleagues at CDC to create a national diabetes prevention program. It's a classroom-style program where people learn about diabetes prevention, or have opportunities for physical activity on a regular basis. And it can be offered in a number of different settings. Number one is training for individuals and the workforce so they understand the burden of diabetes, the importance of prevention of diabetes, but also sort of how to deliver the training. And actually there's a recognition program and certification program that CDC has developed so that people understand how to develop the program. We're looking at expansion of delivery sites and intervention sites through this. That's moving forward. And I should say United Healthcare has decided and is in the process of reimbursing for DPP. There are discussions with CMS as well, with Medicare, in terms of reimbursement for DPP. So I think when that happens, there'll be huge opportunities moving forward. I think the role that pharmacists can play in terms of, there's a program called the P3 program. The Asheville model is another example, which is pharmacists, patients, and partnership, but again using pharmacists to help support in terms of medication adherence, improving the use of medications, and has been shown to improve treatment outcomes, particularly around diabetes and high blood pressure. But these are some nice models. And again, we've got to think about, there are a couple things we've got to think about here. One is, again, issues around reimbursement, if this is really going to scale up. The other is in some states there are laws against pharmacists doing this types of counseling. So I think there are a couple of hiccups there as well. And then the final, I think, important activity I wanted to just briefly mention has to do with community health workers. and the potential of community health workers, again, helping to reinforce what goes on within the healthcare setting as we move forward through there. And there have been a number of studies that have shown the value of community health workers. And I know there have been a number of communities, particularly interested in issues of health equity, that have used community health workers. But again, a similar thread that I want you all to think about here is reimbursement issues for community health, and how do we pay for this to sustain this work long term. The last thing I wanted to talk about is vote and vax. Have people heard about vote and vax? Anybody heard about vote and vax? No? So, you know, more than 126 million people participate in the elections. 70% of them are over the age of 50. And really what vote and vax is about is as people go to the polls and are waiting in line at the polls, you offer them an opportunity to get their flu shot. And in 2008, some 21,000 people participated in vote and vax. It was in about 330 different polling places, and 42 states participated in vote and vax. And so I think, and actually when they looked at who got vaccinated as part of vote and vax, it turned out that 50% of Caucasians, 64% of African Americans, and 67% of Hispanics said that if it hadn't been for vote and vax, they wouldn't have gotten vaccinated some other place. So I think it's reaching a unique segment of the population there. But I would just think about sort of what are the opportunities to be in the community and deliver care and options where people are, as opposed to having them have to go to the health and doing it at a project. So you could think about vote and vax, but I would argue you could think about vote and cholesterol checks, vote and blood pressure checks, you know, et cetera, et cetera. We've got to ensure with those other things that there's appropriate follow-up and feedback to providers. But there are ways to do that. You could think about, there's some communities that have said at the polling place they offer women opportunities, for example, for mammography, to schedule a mammogram, for example. So I think there are novel ways of thinking about this, but again, taking advantage of the opportunity when people are at polling places is kind of neat to say. I also, as we think about each of those domains, environmental approaches, working within the healthcare system, and community clinical linkages, I think it's also really important that we acknowledge the power of the white coat and the power that providers have and sort of their important role that they can do. And particularly, I think, in terms of being able to say some things that we in public health can't say and wish we could say. And so just, I think it's great to see these folks in the room. So whether it's issues around transportation, healthy eating, community clinical linkages, et cetera, I think tapping into the power of the white coat, I think, is really extremely important. So let me wrap up talking for a few minutes just about the coordinated chronic disease program and sort of where we are with that. And as Cheryl mentioned in her introductory comments, we came out with a funding opportunity announcement in September of 2011 with an opportunity to fund states to do more coordination. And as was mentioned, this really was growth out of our experience with what we called the negotiated agreement states, or those 4 states, Massachusetts, North Carolina, Colorado, and Wisconsin. And so we said, okay, what would happen if we were able to give states a little bit more flexibility, but different from the negotiated agreements where we said we're going to give states more flexibility. We're also going to provide one senior project officer that sort of helps in terms of coordinating the work. We're also going to give you some dollars to help. And I think having dollars associated with it makes it a little bit more easy than trying to do this work without any resources. And so the average award to the states was about $730,000, a substantial amount of resources. And really what we wanted to see is we wanted to ensure that every state had a really strong foundation and resources for chronic disease prevention and health promotion. Number two, because we were providing resources to all the states for some of the cross-cutting work that needed to occur, what this meant, and I think this is important for folks, is it meant that the diabetes program, the heart disease program, the arthritis program, the nutrition physical activity program, the tobacco program, those resources could go further. And so I think one of the things that folks need to realize is by doing this coordinated approach, the resources for the individual chronic disease programs can actually go further. I think one of the other things that I think is nice about the Massachusetts model is because as you look at their goals, right? I mean, their goals are still very categorically related. And so they continue to talk about decreasing deaths from heart disease and cancer and decreasing hospitalizations from diabetes. So even though they're doing this coordination, this integration work, it doesn't mean that we don't see outcomes that are disease or condition specific. And I think that's an important message that people need to realize. The metrics are still the same. But because we're doing more coordination, I would argue we're able to bring more people to the table. I would argue that it would be harder for you all to get transportation and housing and economic development and planning and the why to the table if diabetes was knocking on their door and a week later heart disease was knocking on the door and a week later cancer was knocking on the door. But having this coordinated approach, you've got one group knocking on the door. And as I've heard from a number of folks have been crying for this for a number of years. I think the other reality is that we are, and you all, and I think Cheryl did a nice job this morning talking about the impact you all have seen in terms of tight fiscal environments. We, in Atlanta and at the federal side, also are seeing extremely tight fiscal time. So I think that's causing a huge amount of uncertainty about the future. I think at the same time, healthcare reform is creating, I think, some opportunities for collaboration. I think we can learn a lot from what you all have been able to achieve in Massachusetts, but at the same time, there's also uncertainty about healthcare reform as well. Hopefully we'll hear something from the Supreme Court in June, and we'll see sort of what that was as well. But I think given all of that, we think it's really important for you all to be telling your story and to be documenting what's going on, to capture your results, showing your impact. But I would argue it's vitally important for decision makers at the local, at the state, and at the national level to understand what you are doing. I think it's really important for folks to understand the burden of chronic diseases in Massachusetts, that they understand the reach of the programs that you all have, and that they understand as well the impact that each of your programs are having. And so, in closing, what I'd like for you all to do is to go back to those goals and to imagine a Massachusetts where you're able, between now and 27, to prevent 800 cancer deaths. You're able to prevent 1,000 asthma-related hospitalizations. You're able to prevent 1,500 diabetes-related hospitalizations. You're able to prevent 20,000 heart attacks and strokes. You've decreased obesity by 5%. And you've also gotten 34,000 people with arthritis into recommended programs, whether it's on chronic disease self-management or physical activity. And I want you to think about what it will take to get you there in terms of the communities of practice and the specific strategies. I want to spend a minute just talking about this plan, because we are on a tight timeline for this plan, and part of with the states, and we're holding states accountable, and we're pushing, and the folks who are with the plan hear us and understand that. But this is one of the key achievements we have. But two key things I think that are important about this plan. This is not a DPH plan. This is a plan for the state of Massachusetts. And so I think all of you all need to feel that you all own part of that plan, because it is not a DPH plan. It is a state plan. I don't know about you, but I've been involved with a number of plans that when I look at them, we write them, we put them together, and they sit on a shelf. And this is not our intent with these plans. Our intent is that these are very much living documents that get revised over time. And so while you will have some initial strategies that you put in, and you're going to test things out, and you're going to be trying to be as bold as you all can, I think the reality is what I hope happens a year from now is when you look back at that plan, you say you crossed this out because there was no way it was going to work, and you revised the goals, and you did it. And so I think you're going to begin those discussions today. But what I want you to realize in closing, and then we can open things up in case there's any dialogue or questions, is that I think widespread change is within your grasp. I think you have the right folks in the room that can make it. You have the power to do that. You've got good successes over the past. You've got the beginning platform of a really strong, coordinated chronic disease plan in place. And so what this afternoon is about is thinking about those broad-based strategies that will help you to see this broader vision that you have for the state. And so with that, I will say thank you very much. It's great to be up here and to interact with you all. And I look forward to
Hi, I'm Dr. Pascanter, and I'm from Tufts Health Plan. And I'm curious, one of the pieces that I see not really brought into the program is the purchasers of healthcare, the large employer sector.
Yeah.
And you know, as a health plan, we deal a lot with employers, and I think employers have a lot of skin in the game. And so although, as you say, this is not a public health program, it's a state program, I'd be interested to hear what experience you've seen in other parts of the country, you know, bringing employers into this, as well as, you know, any other comments that you have.
Yeah. Good, very good question, and I think it's something we don't traditionally think about, but I think it's an important activity. At the same time we are doing this, so I mean, I think employers need to be there. I think you're right, they're important purchasers. I think the other thing we need to think about, you know, the reality is in a number of states, the largest employer may be in fact state government. And so I think thinking about sort of what state government can do as well in terms of what are the things it purchases and reimburses for. So I think that's an important strategy, and I think a number of states have thought about that issue. I know, for example, the state of Oregon has thought about that as well. But I think you're right. I don't think traditionally we've thought about sort of employers and sort of what they're purchasing, but that's a huge opportunity, and I think it may be another group that sort of folks need to think about in terms of bringing to the table. And I would argue, again, you know, one of the, as Cheryl was doing it, the who's in the room, it was clear the business community wasn't here, so I think you're going to have to reach out. And I would argue that having a coordinated approach, you're more likely to get business in the room as opposed to if it's diabetes, heart disease, et cetera, going individually to bring folks in. But excellent point. Good.
And I would just add a comment that in Massachusetts, we do, through our Mass in Motion program, have a Working on Wellness where we're working with businesses, and we've worked with over 48 businesses now. The GIC, which is the health insurer of thousands of people in Massachusetts, has just implemented a wellness program. And then there's a small business wellness incentive for reducing health premiums with implementing wellness programs that we've helped them develop. And then there are these new co-op pilots of allowing associations to purchase aggregately so they can reduce premium costs by improving their wellness programs. So we are beginning.
So I think the employers have a lot to bring to
Right.
the table to reinforce a lot of what we're doing with their employees.
You're absolutely right.
And I just wanted to add that we're wanting the stakeholders of insurers to be here to work with us to define what pilots we should be doing and working with them to help develop those pilots so that we have the right answers so that we can get reimbursement for whatever we decide to do. And that's why we want insurers to be here.
One of the, I would call it chronic disease control measures that we think has deep impact is that people who take transit to work rather than driving are 50% more likely to get the physical activity every day that they need. Has the CDC and any of your HIAs looked at the health impacts of, let's say, flexing dollars from health, maybe even medical care, to transit? Because every transit agency in America is chronically underfunded, and there's very little expansion of transit going on because of the underfunding. And the dollars that we're spending, the $2 trillion, I think you said we're spending on health care, dwarfs what we're putting into some of the physical environment and infrastructure. And so that relationship between transit and health, I think, is very important, and I'd love to know whether you at the CDC are thinking about that, looking at it, and thinking about states to do pilot programs.
Yeah, so a couple of things that I would say about that I think are important. I mean, you're right about the role of active transit and so transport, and so I think, and so as part of that work, we've been thinking about sort of how do you promote active transport. And as a, now, you know, and so I, but I, oh jeez. So as part of that work, well, two things. I think one is I would think about, for example, the transportation bill, right? I mean that's billions of dollars that's going out, and I would argue that dwarfs the $40 million that's going out around coordinated chronic disease programs. So I mean, I think that's one of the things. But I think sort of how do you influence the transportation bill, for example, so that it is promoting more in terms of active transportation, I think would be what I would say, and promotes more in terms of mass transit. That would be sort of my opportunity that I would think about. I would think the other thing that I think is important for you all to think about would be thinking about sort of how do we bring the transportation community to the table and vice versa so that they're also thinking about health issues.
Can I just respond a
Sure.
little bit, because I think
Sure.
it's important? I would say the transportation community and the active transportation community is very actively engaged in exactly what you're talking about.
Good.
But I guess what I was saying is that actually the spending we do on health and health care dwarfs what we spend on transportation. And we don't think about the spending on health delivery and say, maybe we shouldn't deliver $2 trillion on health care. We should deliver, let's just pick a number. So transportation is big, but by comparison to health, it's nothing. And in fact, the transportation community is actually having that discussion, but it's not engaged, and certainly not engaged, through the CDC on health care spending. I'm not talking about the prevention dollars, which I know are very small.
No, and thanks for that clarification. So I think there are a couple of really key opportunities here. One is through healthcare reform and CMS. Centers for Medicaid, Medicare Services. They are actually beginning to think about sort of what are some innovative ways of thinking about how we pay for health care. And so there will be some opportunities as well through their innovation center, I think, to think more broadly about this. And so there might be opportunities there to think about exactly what you're saying. And thanks for clarifying, because I was thinking public health, but you're talking about more broadly health care spending, and I got what you're saying. Yeah, so I think there may be some opportunities through CMS and innovate and opportunities to do some innovation. And as people may be aware, they put out about $1 billion earlier this year for some innovation awards, and there'll be more to come. I am not sure if any of them right now, because they're in the midst of announcing them, and I'm not sure if any of those specifically deal with active transportation issues. But it might be something, because I know there'll be more coming, more opportunities, and that might be something people may want to put some proposals together. Other questions? You're hearing.
Hi, my name is Pat Bebo. I'm with the UMass Extension Nutrition Education Program. And we work in the communities with healthy eating, physical activity. But I have this opportunity to ask a question out of the box. In some of our community discussions, where does dental care fit into preventative dental care? Because we know that poor dentition is related to chronic disease risk.
Yeah.
So where does that fit in an overall prevention policy?
So it's part of this. I should say within the Chronic Disease Center, we have a division of oral health. That's one. I mean, there are a couple of key things that they focus on. So one is fluoridation, key. The other is dental sealant programs, largely in schools as well in terms of. And so I think we see, and I think it's a great question. Actually, we're going to be talking with the state dental directors in about a week around coordinated chronic disease activities and what are some opportunities there as well. But I think oral health activities clearly can be part and should be part of a coordinated effort. So yeah, so good comments. Good.
And the good news is the oral health program is within our bureau, but in a different division. And so I've been having some thoughts, once we get through this, is to look at other things in the Bureau of Community Health and Prevention and see if we can be more aligned.
One thing is school districts requiring a dental exam before children start school. They need the immunizations, but nobody requires a dental exam. So. Good. Thank you.
My name is Emmett Schmarzo. I work with Councils on Aging, but I have an alternate role being on the board of the Community Health Center in Dorchester. And one of the things that physicians have started doing is writing prescriptions for people that go to the Health Works for Women as part of, this is actually, we're paying for it because we know that the increasing fitness, which is tying into everything here. But more importantly, I think, having them locally where you don't have so many transit issues, people can access things and work or interact with people who are facing similar circumstances in their lives, gives you the strength to do things that the regular 0.2002% doesn't give you. And I think that has to be emphasized, and I just want to put in my 2 cents. Thank you.
Yeah, no, thanks. A really good comment, and I'm glad you raised it. So, I mean, I think two things that I would just say on that. One is having that really key referral, I think is really key, and I think making it as easy as possible for providers to do that. So I would argue, as they're asking people, do they smoke, can they quickly refer them to the quit line? As they should be asking people about physical activity, healthy eating, and say, here are the resources in the community. And I think one of the things we got to think about is how can we make it as easy as possible for providers to make that referral. I think would be good comment.
Hello, I'm Carol Goodnow. I'm the Director of Coordinated School Health at the Massachusetts Department of Elementary and Secondary Education. Massachusetts is one of 22 states that you fund for working with schools to promote better nutrition, physical activity, other things related to chronic disease. It's probably no mistake that the 4 states that are funded for a coordinated approach are also 4 states that are funded with coordinated school health money. It's been invaluable, the money and the other kinds of support from CDC has been invaluable for us in working with schools to get schools who are mainly charged with racing to the top and promoting academic achievement, but to get schools to pay attention to health issues. But the Coordinated School Health Program at CDC, as far as we know and have heard at this point, is scheduled to sunset next February. Can you tell us anything about the future of CDC support for working with schools on health issues?
Sure.
Off the record, of course.
No, and this is totally on the record. So two things. Well, let me back up a little bit. What happened last year with the budget is Congress decided to split what was one funding line for school health activities at CDC. And so we had one budget line, but part of it went to do sexual health and HIV work, which is in one center at CDC, and the other went to do chronic disease-related work. And Congress said, because one is in one center and one is in the other, Congress said we need to split those up. So now the HIV, STD, Sexual Health Center is managing that part of coordinated school health, and we in the Division of Population Health are managing the chronic disease asthma activities. And I think as you think about opportunities for coordination and collaboration, and there's one setting and it's schools, you ideally want one-stop shopping in terms of all this activity. But we are working together. We are working very closely with the folks now in HIV, STDs to coordinate the work, and so we'll move forward. So that's sort of the background in terms of the budget stuff. The reality is that coordinated school health activities will continue. There will be a new funding opportunity announcement that will be going out. So I would not be concerned at all about that. The resources will be going out to the states. We're right now beginning to draft that new funding opportunity announcement. Now, I think the one thing that will and it will be, as we've done every 5 years or so, there will be a recompetition. And so, as you may know, sometimes states get funded, they may be funded for a couple of years, they've got to recompete for this, and they may not continue to, depending on how they do, they may or may not be funded. So I think that's important to do. But there will be a new FOA that will be coming out, okay?
Great.
So, and that is totally for the record, and so if you talk with other folks who hear that, you can say, you heard from me, there will be a new funding. Sure.
And actually, through that funding, we have at DPH York
Yes.
who coordinates with the schools and the Department of Public Health.
Hi, I'm Stephanie London. I'm from the Prevention Research Center at UMass Worcester. Hi, nice to see you. My question has to do with the role of stress and mental health in this context. A large proportion of the population experiences stress and low levels of depression and anxiety, and these are not only independent risk factors for unhealthy behaviors and chronic diseases, but they also affect disease management, and there's this really complicated relationship. And I haven't heard anything about that, and I'm wondering what your thoughts are on how we integrate mental health into some of the work in chronic diseases.
Sure. A couple things. One is you may want to look at the IOM report that I talked about, Matt, Living Well with Chronic Illnesses, because they talk a lot about sort of linkages between depression and chronic conditions. We know that people who are depressed, if they've got diabetes, treating that depression will help in terms of their diabetes, blood pressure control, et cetera, et cetera. So yeah, there are really important linkages with this work. So I think a couple of things, and I'm going to highlight one of the activities out of one of your sister prevention research centers, and that's PEARLS, which is a community-based intervention for people who suffer, particularly elderly people who suffer from mild to moderate amounts of depression, and has been shown to be effective in terms of decreasing symptoms of depression, improving chronic care. And so, one of the things, and they've been working with group health and others around reimbursement issues for PEARLS to try to scale it up. And so I think as you think about sort of those community clinical linkages, I think one could think about programs such as PEARLS and others that might be effective in terms of treating depression and those other things. But again, I think thinking about sort of how that then goes back, I think from our standpoint in the Chronic Disease Center, sort of how that goes back to the chronic disease outcomes that we want. But I think it's an important issue.
Do you think that there is a role for bringing in, partners who primarily focus in mental health or organizations that have that kind of an expertise in?
Yeah, so I mean, I think, well, two things. I mean, I think that's up to the state in terms of how they want to do that. But I do think, given the burden, given the comorbidity, they may want to look at sort of bringing in some of the folks, the mental health folks, the behavioral folks as well. And I think, again, I'm going to say two things about a lot of this work. Number one, as Cheryl says, I think one of our metrics has been to really think about doing a few things well. And so I would argue, number one, to be somewhat focused in terms of work, particularly initially, see how things go, and then expand out. The last thing that I would say is that, as I said earlier, I see these plans as very much living documents, and so there are going to be some gaps, there are going to be some misses, and so as you think about that work, I think it's important that we say, we really missed this segment of the population we need to think about, and then potentially bringing other folks to the table. So, my 2 cents.
Thank you very much, Dr. Giles. This really isn't about creating new work for us. It's about looking at the work we're all doing sort of individually and figuring out how, if we come together, we can leverage even a bigger impact. And so with that, Leah Susan's going to walk us through the work of the communities of practice this afternoon and how we'll be able to start this effort together.
So I think, thank you, Dr. Giles. I think that, he's always great to listen to. I always learn something new. But I also think when he was talking about the we and all the different partners, I think it really laid itself out well for introducing the communities of practice and why the group chose the model that we did. And I think it was, you'll see from the summary of the plan is that there was a lot of conversation around the goals, but then the group that we had brought together earlier really felt that we had to fine-tune and pick some priority objectives to really start our work. Otherwise, you could be doing everything in the kitchen sink, and we don't have the opportunity and the ability to do that, but we really wanted to fine-tune that. So it really, the group felt that let's come up with 11 priority objectives and then put those into 7 communities of practice. So what I want to do is I want to talk about the communities of practice and how the approach that we use to get there, and then really kind of give more of an introduction to the 7 communities of practice that will be taking place this afternoon to give people have selected where they want to go, but in case there's some wanting to move, we really wanted to kind of talk a little bit more extensively about what is in each one. So as I said, as part of the plan that we have, is that in addition to our individual agency efforts, the partnership members will engage in collaborating planning to address 11 priority objectives which correspond to the strategic areas that we have set forth and the goals that we have. And these particular objectives were selected because they provide opportunities to test and evaluate strategies that will inform similar efforts to address other risk factors or diseases in the future, involve strategies or policies that can have statewide impact. Again, we want to have very broad impact on the population, increase the scope of health promotion and chronic disease management in Massachusetts and fill gaps, offer opportunity for each of our partners to work in a coordinated way to achieve one or more objectives, focus limited resources on high-impact initiatives, again, when really pulling things together so we can really target specific areas when we have declining resources or limited resources. They're not declining, they're limited. And really align with priorities of the 2 national campaigns or initiatives that have come out in the last couple of years. It's really important for us to kind of be looking at and focusing on. One is the Million Hearts campaign, and then the other is the National Prevention Strategy. So if you aren't familiar with those, I think if we can provide linkages to those, because I think they're both really important for people to look at. Looking at one clinical and one, the National Prevention Strategy is really doing what we've been doing in here in Massachusetts, is bringing a lot of different disciplines together and federal agencies together to look at prevention. That prevention is not just about health and human services and CDC. It's about, again, transportation and housing and education and criminal justice. So the organized, as I said, the group worked together to organize the priority objectives into 7 communities of practice. The infrastructure of the partnership, and again, it's our partnership collectively. It's not a DPH, has been said a couple times, it's us working collaboratively. The partnership will be comprised of 7 communities of practices or work groups, which will meet regularly to plan, implement, evaluate, and improve strategies to achieve the assigned objectives. Each community of practice comprises of a subset of the partnership and has members whose knowledge, skills, and experience are suited to the objectives that has been selected. And again, we're really encouraging people to self-select into the group that's most appropriate for the work that you do. The communities of practice will utilize data on health disparities when developing strategies to ensure that health equity is addressed in all strategies in order to improve the health of those most at risk for chronic disease. So I go back to the example Dr. Giles used about when somebody was doing a healthy corner store initiative, and first you went with who were the corner stores that were early adopters and willing to work on it. Well, then you saw that they were not necessarily in the communities that needed it most. So that we have really assigned one of our staff epidemiologists and evaluators to work with each community of practice. So we are continually looking to make sure that the work that we're doing is going into the communities of the greatest need. So we have looked at that. So I wanted to walk through each one of the communities of practice. So the first is the healthy eating community of practice. So as we know that good nutrition is known to lower people's risk for obesity and many other chronic diseases. Among the various strategies for addressing this risk factor, the healthy eating community of practice will focus on increasing fruit and vegetable consumption, both children and adults in the Commonwealth. And this was an interesting conversation that went into this one because I think we really are focusing on fruit and vegetable consumption, but I think the conversations that we had, you could have looked at decreasing sugar-sweetened beverages, you could have looked at sodium, you could have looked at calorie-rich, poor nutrient food. So it's like, how do you fine-tune that group? But I think that group is going to continue to have some of those conversations. But again, I think if we're working towards increasing fruits and vegetable consumption, you're automatically working towards decreasing some of those other things. So that group, under the facilitation of, where's Claire, and because I want to also get people to recognize the faces that you'll be seeing later, so you can follow. Claire Blaze and Cynthia Barrell are in the back, so they'll be facilitating that group. And the healthy eating community practice will work together to increase the percentage of youth and adults who report eating 5 fruits and vegetables per day by 1.5% by 2017. So the group will work together to identify the evidence-based strategies that people are working on and where are we going to aim to get to that goal. So Claire and Cynthia will facilitate that group, and that group will be meeting in the AV1 room on the 3rd floor, so one level down. And the curiosity I have right now is, can we use stairs in this building, or do you have to do the elevator? So maybe we should think eating community of practice, which leads to the conversation around walking downstairs. The physical activity community of practice. So as we know, regular moderate to vigorous physical activity can improve overall health, reduce obesity, and reduce the risk for some chronic diseases. This community of practices focuses on increasing physical activity among youth ages 3 to 18. Although physical education is mandated for every student in Massachusetts public schools, there are currently no policies in place to ensure that children of all ages engage in moderate to regular physical activity during the school day. And I think the other focus of this group will be looking at that's this in-school time. What about the out-of-school time? How are kids getting to and from school? And what are kids doing after school and on the weekends? So again, thinking about opportunities to increase physical activity. So this physical activity community of practice will work together to increase the percentage of youth ages 3 to 18 who report in engaging in moderate to vigorous physical activity for 60 minutes on 5 or more days a week by 3% by 2017. That group will be facilitated by Laura York. It's right there, for those of you behind the big beam. And that will also be on the 3rd floor in AV room 3. The built environment community of practice. So built environments, and I think this is something that Dr. Giles was showing as well, that support active living, lead to healthier communities. Physical activity is associated with decreased obesity and reduced risk for several chronic diseases from arthritis to heart disease. A complete streets policy encourages the creation and operation of road networks that support physical activity by enacting change at the policy level. So Massachusetts residents who live in communities with complete streets will have increased opportunity to be physically active. The built environment community of practice will work together for the goal of it by 2017, at least 5% of Massachusetts residents will live in communities with a complete streets policy. That group will meet right here with me. I guess I don't move through the entire day. So right here is the Complete Streets group. And I think that when we were looking at the developing of the goals, you'll notice that this is, Complete Streets are an evidence-based strategy to get people more active. So I think when you're working in your groups, that your groups are looking at, like for example, the fruit and vegetable, one about increasing fruit and vegetable consumption. What is the type of evidence-based strategy, similar to how we're working on Complete Streets to get people more active, that you would do in your own group? So you'll notice that they're in different stages, so I think each group has different levels of work to do to get to the objective. The fourth community of practice is tobacco living. Smoking in the home has negative health consequences, not only because secondhand smoke is a known carcinogen and risk factor for cardiovascular disease, asthma, and cancer, but it also because secondhand smoke can act as a trigger for asthma attacks. The tobacco-free living community practice aims to minimize people's exposure to secondhand smoke through the promotion of smoke-free housing policies and multi-unit dwellings. The tobacco-free living community practice will work together to increase the percentage of smokers who report that they have a no smoking in the home policy by 10% by 2017. So Jean Zotter, from our asthma program, will facilitate that communities of practice. And that group, I don't know if it was ever published where they were going to go, but you're actually going to move. It's going to be into the clinical preventive services and population health management community of practice. We'll focus on increasing and improving the delivery of clinical preventive care to prevent chronic disease, detect chronic diseases early in the disease process, and appropriately manage existing chronic conditions. To this end, the group will focus on 3 clinical preventive objectives related to colorectal screening, vaccination against influenza and pneumonia, and smoking screening and cessation counseling, as well as objective targeting the management and treatment of high blood pressure. So the clinical preventive services and population health management will work together to address 4 objectives. So this group has a lot to look at. Increase screening for colorectal cancer by 5%, increase vaccination against influenza by 3% and pneumonia by 4%, among populations for whom these immunizations are recommended. Increase the percentage of smokers who are screened and counseled on tobacco use in a healthcare provider's office by 4%. And increase the percentage of people whose blood pressure is within normal range by 2.5% by 2017. So Anita Christie and Patty Daly, where are they? There's Anita. Oh, Patty's right in the back corner. Will be facilitating that group, and that group is meeting in the community and healthcare linkages community of practice. So many people who are at risk for chronic diseases or currently have one or more chronic disease lack the resources that could help them decrease their risk, such as access to preventive services, nutritious food options, or availability of safe places to engage in physical activity. The community linkages community of practice objective aims to connect clinical settings to community resources that can help individuals prevent and control chronic diseases. The community linkage will work together to develop and disseminate at least 3 best practice models for better clinic-to-community linkage for preventing and controlling chronic diseases by 2017. I think even some of the information that Dr. Giles was talking about, this is really, I think, a cornerstone, and really, not that all of our communities and practices are important, but I think this one has a really opportunity to really help inform some of the real, true integration between the 2 sides. So this will be, Marilyn Gardner is facilitating this one. She also she's right there in the middle. And they're in AV4 on the 3rd floor. And finally, the improved access to state and local data community practice. Data collected by the Department of Public Health is used to support policy that improves the public health of Massachusetts. The improved access to state and local data community practice has 3 aims: increasing data availability at the community level, improving data linkages, and supporting other partnership evaluation efforts. The improved access to state and local data group will work together to develop and disseminate 2-page public health community profiles for cities and towns and legislative districts across the Commonwealth to describe the health of communities, and identify and pursue other collaborative data initiatives that will inform and improve public health strategies to address chronic disease, i.e. the partners who have data that could be integrated with data and be so it's part of what data we have, and there are other people in the room who have great data sources. Then how can we work together to pull those together? So Joshua Nimbosi, there's Joshua in the back. We'll also be staying in this room I think on the other side. Being here and by going to that community of practice, you're committing to participating in that community of practice. We want it to be something that's relevant to your work and something you're interested in working with collaborative partners on. So if there, sometimes I don't even remember sometimes what I signed up for. I don't know if people go that way too. But I think it's also hearing, like seeing one thing and then hearing a little bit more, hearing Dr. Giles speak today, hear Cheryl speak today, and you'll hear the commissioner. It may change your mind of what you want to work on, and I think that's fine. Select a representative to the leadership group for the partnership. Determine, and so that could be the same person. It doesn't have to be the same person if you want to divide up responsibilities, somebody to co-facilitate and then somebody to work with the leadership team to bring this together. And when we meet this afternoon, determine how often you will meet and how you will meet. I mean, I think it's going to be the group's decision about, do you meet in person, do you meet virtually? And we're going to have resources, and again, we should have recognized Peggy, who was the backbone behind the scenes person pulling this all together as well, and she's going to help the facilitators and the co-leads to really do the logistics for the meeting. So we will have the opportunity, if it's in person, if it's on the phone conference call, so that your group will decide how you want to meet and how often you want to meet, knowing what you need to accomplish to get to or achieve the priority objective. So again, it's really, the communities of practice are vital to helping us achieve our goals, because that's the work that's being done across the Commonwealth to get us to the point of achieving the reduction in heart disease, heart attacks, reduction in asthma that we talked about earlier. So just a couple more minutes on the actual plan. So it's going to be released in August, and again, this is the initial draft of the plan as we talked about. And it will contain information about all partnership organizations, including current strategies, affiliations, and contact information. And if you have not yet provided your organization's information for the plan, please give it to Peggy. So again, and then in 2013, we will update the plan to add the collaborative strategies and activities that are going to be developed within this year by the communities of practice. So again, really, we have an initial plan based on the work that's being done, and then the communities of practice are going to really look at that work and how are we going to do that together, and then that's going to be what's going to be added. The collaborative strategies and activities that are going to be developed by the communities of practice are going to be added to the second iteration of the plan. And I'm glad that even Dr. Giles is saying they are the living, breathing document, because that's what we want. We didn't want a document that we create something that then nobody's going to do anything with it. So we really felt it's important to start with one thing, work this year to fine-tune it, to see what really the collaborative efforts are, and then continually each year to revisit that. And we updated information with all the partnership organizations, because if you'll see, currently we only have the people who participated in early versions of the meetings, but we have a lot more people and a lot more organizations in the room. So we really want to talk about that, because I think it's important for people to see that work around chronic disease and health promotion is a collaborative effort among organizations, disciplines, and stakeholders. So we'll make sure we do have until the commissioner will speak at noon, so we want to give the opportunity for people to get their food, network a little bit, and then still eat their lunch while the commissioner's here speaking at noon. Okay? All right. Thank you.
I believe so. Okay. Now, they said they were setting it up.